The title of this lecture is Correlative Imaging in Pediatric Bone Diseases, Bone Scan and PET with fluorine. In fact, as we have seen this morning, the correlative imaging is the best diagnostic tool than the image specialist we can offer to the clinician, with the correlation between anatomy and function or metabolism. And the collaboration between the radiologist and us is crucial for this. Okay, the SPECT-CT and PET-CT are really the emerging techniques in nuclear medicine, but with some differences between children and adults. In children, you know that we have to apply the dosage cards, etc. As mentioned before, it's easier to, and the quality of the image is higher if we obtain spot images than whole body images. The detector is closer to the body of the child compared to the resolution of these both images. And what about to decide to perform a SPECT or SPECT-CT? It's very well known that the sensitivity of the SPECT is higher to the planar images to detect small lesions, like in this case of spondylolysis. But I think that we don't have to perform a SPECT-CT instead of a SPECT due to the dosimetry if the SPECT is normal. Then we have to compare different modality images and avoid to perform unnecessary CTs. For example, in this case of this spondylolysis, it was a football player. There's a back pain, as explained before. The spondylolysis are very frequent in this kind of teenagers, and we can see on the planar X-ray that the lesion is very congruent with our. Then do not perform SPECT-CT if not necessary, and this is due to the dosimetry. Okay. In pediatrics, the CT scan as part of the SPECT-CT in an hybrid system increases significantly the dosimetry, as well in SPECT-CT that in PET-CT. And that means that we have to perform only the SPECT-CT for diagnostic purpose and never as a routine. If there is a clear indication, then we can do a low-dose CT as part of the SPECT-CT, or a diagnostic CT instead of a separate CT if we have a device prepared to obtain a diagnostic CT. In this case, for example, of condylar hyperplasia, the SPECT-CT images help a lot to looking at the fused images to see that really the hypermetabolism is in the condyle. Or in this other case, it's an osteoblastoma in a cervical vertebra, and then the planar images or the pinhole images here are clear, but the SPECT-CT images are much clear and help us to localize very well the lesion. In any case, be sure that a diagnostic CT has not been performed recently. Think about the possibility to fuse the CT and the SPECT using software, or to make a correlative image, a comparative image, and to perform the SPECT-CT only if there is a lesion and you need to localize it, especially in the body and especially in young children. Well, and what about the PET or the PET-CT? For FDG, we need the attenuation correction, and we need also to localize very well the anatomy of the lesions. For this reason, for the PET FDG, we need to perform a CT, as mentioned this morning, and this CT can be diagnostic or not diagnostic, and usually with a low dose, even if it is a diagnostic CT. But if we perform a PET with fluorine, we are studying only the bones, and the bones are mostly superficial. That means that we don't need really the attenuation correction. And if we don't perform the CT, then that means that we diminish by 2/3 the dosimetry of the exploration. Well, how to organize a little bit this lecture? I think that we have, for the bone diseases in pediatrics, we have to inform or to orient the pediatrician who asks for the diagnostic test to study a children with bone pain. We have to explain the advantages and disadvantages of each one of the available technique, X-rays, ultrasound, scintigraphies, etc., and comment in each clinical situation or clinical symptom the indication, the utility, and the level of evidence of each test. Some years ago appeared the last update of this document. The first document was from 1999, and it has been published several updates, and the last one is not really very recent, but it's a good document, and they advise, committee of experts advise us what to apply, what test to apply in each clinical situation, and what level of evidence. For example, it can be a level or recommendation A, B, or C. And for example, for the child abuse, the two tests to apply are the skeletal survey in radiology or the bone scan, okay, with different levels of recommendation. And that means that they explain that the bone scintigraphy is useful to detect occult fractures and has a high sensitivity. In babies under 1 year of life, usually all the diaphysis has a hyperactivity, and the blood pool image is useful for the differential diagnostic between old and new fractures, because the new fractures are blood pool positive and the old lesions are blood pool negative. Here on the right you can see one example. Can you see the thicker, mild increased activity of this femur compared with this one, and the femur seems to be thicker than the other one, and here the same for the tibia. In fact, he has a fracture in all these diaphyses and in all the tibial diaphyses too, and it was a battered child. Okay. This is another case. Look at a skeletal survey with incredible lesions on the skull. And these are the images of the bone scan with the blood pool image here. And here you can see an increase of activity on the right humerus, okay, here and here. And on the bone images, there is an increased activity on all this humor, and also on the iliac bone, and also on a rib. I think it's here, with blood pool positive. The positivity of the blood pool indicates that there are recent fractures. Well, then in battered child, we have been performing during years bone scintigraphies to detect, but the lesions detected on the bone with the bone scintigraphy have a low resolution with a non-optimal specificity. The blood pool helps a lot to detect inflammation and helps us to differentiate between old and new bone fractures. But the problem is some old fractures can continue to be positive on the bone scan, but negative on the blood pool image. The skeletal survey detects the bone fractures, but with a lower sensitivity than the bone scan, and with false negative results in some very recent lesions, and detects all fractures usually. The dosimetry is higher, and it is not a whole body image. And what happened with the PET with fluorine? The TEC with fluorine detects the bone fractures with higher sensitivity than the bone scan and the X-ray survey, and with a very good image resolution. The dosimetry of the fluor is very low, lower than the bone scan, if we inject a very low dose with a good PET-CT scan. For example, I'm going to show you in some minutes images of a baby of 9 months in which we have injected just half a millicurie of fluorine. That means that this dose is lower than those from a bone scan and without CT. And with a small amount of fluorine, we can obtain images of the whole body without CT, and we perform only CT or X-ray in the areas with hypermetabolism with fluorine. That means that it is possible that this technique can be introduced as a technique all-in-one for a quick diagnostic of the battered child. And compare the quality. This is the image performed with half a millicurie of fluorine. And here, this is an old scan in an older boy, excuse me. Compare the quality of the images. This is performed with several millicuries. This is performed with just a half a millicurie and 3 minutes per bed on the scan. Look at this image, this MIP image. You can see easily the extent of the fractures in this battered child with multiple fractures in all the body and in the skull. And this has been obtained without CT and without attenuation correction. Well, going to osteomyelitis, I'm sorry because I'm going to repeat things, but well, it's not. The X-ray is a first initial investigation to be performed. The MRI is accurate and demonstrates infection, especially in the spine. The CT can demonstrate the existence of a sequestra. The ultrasound detects the subperiosteal abscess and has a high false positive rate. And the bone scintigraphy with the 2 or 3 phase bone scan is more sensitive than X-ray in detecting focal osteomyelitis and is useful in a suspicion of osteomyelitis without focal symptoms. And the leukocytes, the white blood cells scintigraphy confirm the infection in bone or joint, but have false negative results in spine. This is one case of septic arthritis of the knee. You have here the vascular images and the blood pool image showing an increased perfusion of the lateral part of the right knee, and the X-ray, and the bone scan are completely normal without increasing activity on the lateral condyle. That means that it's a pattern of arthritis without bone involvement. Remember that we can have a diffuse increased uptake when we have hyperperfusion, but in this case it was not the case, and we have not abnormalities on the bone scan. This is one special case, the hip arthritis. Remember that in case of hip arthritis or in arthritis of the scapula, you have always to value the perfusion of the femoral or the humeral head. Why? Because in case of arthritis, it can be an increase in the pressure inside the articulation, and the perfusion of the head can be decreased or can be zero. And this is an emergency for the traumatologist, because he has to intervene and has to diminish the pressure inside the articulation. This can be also due to a septic embolism, but the theory of the increased pressure inside the articulation is more accepted. In this case, this bone scan has not been reported adequately, and it has been reported an osteomyelitis of the neck, but they said nothing about the absence of perfusion of the femoral head. and that means that they has not been intervened. And 9 months later, we found here irreversible sequela on the femoral head. This is another case. It's a 7-year-old boy with a lytic permeative lesion on the right tibia, with medular diaphyseal abscess on magnetic resonance imaging, and in the bone scan we find concordant collisions in these areas. And 2 years later, the boy came again for pain and fever. On the X-ray there is a sclerosis, and these are the images of the bone scintigraphy and the follow-up 2 years after the acute osteomyelitis. What do you think? The blood pool is positive or is negative? I think here we can see really an increased blood pool of all the tibia. Yes. And what happened in the later bone phase? There is a deformity of this tibia with diffuse increased uptake in all the diaphyses. Yes? And how can we report this? Active osteomyelitis? It is possible, but we cannot be sure, because after a fracture or after osteomyelitis, the bone scan can persist positive during years. In this case, the positivity of the blood pool suggests a reactivation of the osteomyelitis, but it's pandiaphyseal and it's not clear. What does we have to do? Yes?
I would just reflex sympathetic disc. Why not?
With fever.
Okay, it is a sequel. We found the whole shaft of the tibia with the pre-articular uptake like that. We can think about a deformity of the limb.
Yes, but the problem is the fever. And then we have to discard a reactivation of the osteomyelitis, a chronic osteomyelitis. Well, we perform white blood cells scintigraphy. Yes? These are the bone scan. You can see in more detail all these lesions, and these are the images of the white blood cell scintigraphy. What do you think now? Is there a reactivation? Yes? Where? In all the diaphyses? No, just in the submetaphyseal region. Okay? Okay, this uptake indicates a focal septic activity in this chronic osteomyelitis. Yes? And what about the PET or PET-CT for osteomyelitis? In PET, we can perform two kinds of exploration. We can perform a PET with fluorine, that means an excellent quality bone scan, or we can perform a PET with FDG. And with FDG, we are going to detect the infection with a high sensitivity and a good image resolution. One is one with a CT, and the other one can be with or without a CT. Okay? This is one case that I showed you this morning. It was a young lady of 30 years with infection of the right foot after a car crash. And I show you the coincident results of the FDG with lesions on the bone and the soft tissue, and the fluor PET with lesions only on the bones. Okay. Well, going to the Perthes disease. This is a 4-year-old boy with suspicion of Perthes disease with abnormal left femoral head on the X-ray, with concordant with that MRI imaging. And these are the bone scan images, in this case with two phases, with an inflammation in the blood pool image, with a cold area on the pinhole images of both hips. Right hip completely normal, left hip cold area with a lateral pillar. And remember, as explained this morning, the prognostic signs of the Perthes disease The extension is one of the prognostic signs. The existence of an external column with a different degree of uptake is a sign of good prognostic. And also in some severe cases of Perthes disease, there is a diffuse hypoactivity of the proximal metaphysis of the femur. And in these cases, the neck is not going to grow as much as they can. Going now to the bone lesions with aggressive signs. In these cases, the reference technique will be the bone scintigraphy, the PET-CT, and the MRI. Here you can see a case of an osteosarcoma studied with X-ray bone scan, a spect CT of the bone scan at the diagnosis. Look at these images of diagnosis. It's really a very advanced case with a very bad prognostic. Look at all the lesions on the lungs and the extension of the regional tumor. This other case is the opposite. It's also an osteosarcoma, in this case of the proximal submetaphyseal area of the right tibia. And in this case, we perform a PET with FDG, and the diagnostic extension is completely negative, and it is just a local tumor. Okay. This tumor has been submitted to chemotherapy, and after that, it has been intervened with a salvage surgery, putting on the leg a big prosthesis with a lot of things to immobilize the prosthesis, and this PET was performed after 6 months after the surgery, more or less, and the PET was asked to be performed by the oncologist or sometimes by the traumatologist. Okay. In this case, it was by the oncologist, and the activity around the prosthesis was completely normal. The PET can detect local residues around the prosthesis, and 1 year later, the boy come again to the hospital because he has pain on his leg after a sport injury. And then we perform a bone scan. And what do you think about this bone scan? What happened? The clue are the spect CT images. Where do you see hyperactivity on the spect CT images? Okay. And this can be a recidive? Yes, it is attenuation corrected. What are these activities? If you see at this image, you can see that due to the sport injury, it has been a movement of the prosthesis, and now there is an increased activity around just the immobilization of the prosthesis, and that means that it's not a recidive, it's just a trauma over the yes. No, it's just after a trauma. It was like a small fracture. Okay, and referring to the Ewing sarcoma, Tim explained us many things. I just want to show you some images. Ewing sarcoma sometimes in the bone scan has a quite high uptake, and it's easy to differentiate, but sometimes the uptake is very mild. This was a girl with a costal Ewing sarcoma resected previously, and she come again to the hospital with this mild uptakes. In fact, there were metastases, but it's sometimes very difficult to identify. And sometimes the PET with FDG, it's much more useful for the follow-up of the Ewing sarcoma, much more than the bone scan. But in fact, on the oncologic guides, the bone scan continue to be as the recommended technique. Or, for example, in this case of an Ewing sarcoma of the right tibia, look at the very mild increased uptake here. It's very difficult to suggest to the pediatricians that this is an Ewing sarcoma, and it's much more easy to study with PET FDG. look at the image with PET FDG and compare with this uptake with this one. I think that in the future, I don't know if you agree, but I think that in the future the sarcomas will be followed with FDG and not that with bone scan. And some words about the bone metastasis. In this case, it was, I think it was 7 or 8 years old girl with knee pain and fever, and the radiologist find an aggressive lesion on the left femur distal metaphysis with a retroperitoneal tumor on the ultrasound. We perform a bone scan with a high uptake in the abdominal tumor. Of course, it is a neuroblastoma, and with a submetaphyseal activity nearly in all the long bones. That means it's a stage 4 neuroblastoma with uptake in the tumor, with metastases in all the vertebrae and on the long bones. And if you compare these images with the images of MIBG, the MIBG show uptake on the tumor, but very mild uptake, very less uptake on the extremities that the bone scan. And perhaps for this reason, the bone scan continue to be recommended in the initial staging of the neuroblastomas, not in the follow-up, but yes, in the initial staging, because of the long bones, sometimes the manifestation of the bone metastases are more clear on the bone scan than on MIBG image. And if we compare, if you asked me this morning, the MIBG and the FDG on neuroblastoma, there have differences between lesions with MIBG negative, FDG positive, and the contrary has been described in several papers. And in fact, it seems that the recommendation is to perform FDG PET in cases of clinical or radiological discordancies, or in case in which the MIBG converts in negative when has been previously positive, or with a neuroblastoma initially negative. In these 3 cases, it is advisable to perform PET with FDG. Here we have one case of recidive of the neuroblastoma stage 4. It is a recidive with multiple metastases on the spine, with MIBG uptake and without FDG uptake. And in this other case, this is the contrary. Here you have more lesions on the PET scan than on the MIBG scan. That means that both explorations probably are complementary, and probably here we are obtaining images of the different cellular lines of the tumor. You know that all the neuroendocrine tumors are multicellular, and we have the tools to study different cellular lines. And of course, there are lines with FDG uptake more undifferentiated, and there are lines with MIBG uptake, and they are differentiated tumors. One case of Langerhans cells ichthyosidosis. The PET with FDG is an exploration all-in-one again. If you perform an FDG, we can detect very easily all the extension of the lesions, as this boy with multiple involved vertebra, femur, etc. Here, here on the thorax also. Here a vertebra, and here a big lesion on the omoplate. Okay. Back pain or neck pain, it's not frequent in children, and it's always organic. This is a case of a 13-year-old boy with a spinal pain at the thoracic level, more during the night, with normal X-ray. And here, what do you see? We see a very focal lesion, a very small one, with a very high uptake. And if we compare with CT, we perform the spect but not the spect CT, and comparing with a diagnostic CT performed just 2 days before, then we can see that this is a nidus, and here we can see the lesion. We perform a radio-guided surgery with a nidus resection, no laminectomy, and an excellent evolution of this boy. What about the focal bone pain? This is a 13-year-old boy with a leg knee pain after exercise. And these are the images. What do you see? You can see very well on the magnetic resonance that there is a lesion here with a mild uptake on the bone scan, and the diagnosis was of non-ossifying fibroma. But in this other case, we can see it's more or less the same history, but it was a football player, and he has pain on the left leg, and here we have a periostic reaction. We perform a bone scan, and there is a lesion with a mild increase in the blood pool here, and here a very focal lesion, nearly linear. This has been reported as a possible stress fracture, but the family has been very anxious, and they asked to perform a magnetic resonance. And the magnetic resonance has been difficult to interpret, as well as the CT, and they describe aggressive signs. They perform a biopsy, and the pathologist had a lot of problems. And the key point was 2 weeks later, and the X-ray follow-up showed that it was really a stress fracture. Okay, the future, as mentioned before, are the correlative imaging with the image fusion, with the molecular imaging, and the straight collaboration between the imaging specialist. And we need the good clinical question to know what do we have to answer. And this is all for this lecture. Thank you.
Thank you, Dr. Isabel, for your elegant lecture. Do you want to proceed to clinical cases since we are ahead of our time, or do you want to take a tea break?
Up to you.
Let's proceed with the clinical cases.
You are the moderator.
Okay, please. Thank you.
Okay, which is a treasure? Yes? A volunteer? MDP? No. Fluorine, yes. The blood pool. And what abnormalities do you see? Is something abnormal? This is the PET image obtained just after the fluorine injection. Okay? I think it's here, it was 3 or 4 beds and 1 minute per bed without CT. That means that we have obtained all these images during the 5 minutes after the fluorine injection. It's like a blood pool image of a bone scan. What is abnormal? Is something abnormal or not?
Yeah.
Yeah? What? What about the chest? Yeah? He has the stomach on the right? Okay. It seems that we have 2 big areas of abnormal uptake on both sides of the thorax. Yes? What do you need now? The late images? Something abnormal? Well, the tracer is fluorine. And this is 45 minutes after the injection. There is a little movement of the left leg, yes? Because we have two left femurs. What does we have? What does we have to have now? Well, the first thing that we have to say is that after these images obtained without CT, we decide to perform a PET CT later on, because of course there are a lot of abnormalities, okay? And that means that these MIP images have been obtained with PET CT. Do you want to see the fused images? Well, these are the MIP images of the blood pool on the left and the fluorine on the right. And these are the fused images. Low count images, but it's not a problem. They are diagnostic. Oh. Do you want more images? Oh, I'm sorry. It was a battered child. There are a fracture with pleural involvement, inflammatory pleural involvement. Okay. Yes. No, it's not a chest infection. It's a trauma, a bilateral trauma. More seen on the soft tissue involvement than on the bone involvement. Okay. And on the leg, you can see that there is nothing. Okay. This is another case. It's a 1-year-old boy with a suspicion of acute mastoiditis. And this is the skeletal survey. Some comments? There is a radiologist here? No? Well, what to perform now? Bone scan and MRI. What about the bone scan? Is there any abnormality? Yes, but on the planar images, can you see left scapula? Yes, very well. It seems to be insufflated, isn't it? This was not detected by MRI. They missed the scapula. Okay, and then fused images. Okay, we perform under the suspicion. What was really the end diagnostic? We perform a PET with FDG. How many lesions can you see here? This is the lesion in the scapula, okay? And this, what is this? This is a lytic lesion on the skull. That means?
Could be histiocytosis?
Yes. Langerhans cells is histiocytosis, okay? Okay, look at the discordance. Here it's much well seen here. The PET-FDG is the expression all-in-one for the histiocytosis, and the problem that we have is the skull, because in the skull, due to the high cortical activity, it's easy to miss one lesion like this one. Sometimes you can see, but not always. Okay, and now one case in one adult, to change a little bit. Which are the tracers? What? One is FDG and the other one is fluorine. Yes, on the left FDG and on the right fluorine. And both are normal or abnormal? Abnormal. Which is more abnormal? The fluorine. Yes? And what can we see on the fluorine PET? Many. Yes, skull lesions, vertebral lesions, costal lesions, In pelvis also, yes? And with FDG, can you see any of these lesions? Few. Less lesions than with fluorine, yes? And you are working with adults. Well, what do you suggest as diagnostic? The bone scan was normal. Normal. In which oncologic disease we can have a normal bone scan with a lot of bone metastases? Myeloma. Okay. Another case. It's I don't remember the age, but it's around 4 or 5 years old, with fever, severely ill, with cardiac surgery performed 2 or 3 weeks before. And they sent us the child for to discard an external infection. And this is the image of the coronal PET. Do you want more images? Oh, no. I have no more. Oh, I'm sorry. I'm sorry, because I have more beautiful images. But what happened in the mediastinum? We can see some activity, like multinodular. No, I'm sorry, I have no more images. The mediastinitis. Okay, it was a big increase of activity at the sternum level, but with a big mediastinal mass and activity around a lot of mediastinal collections. Okay. No. There are multiple mediastinal masses. No lymphodes, no. Abscess. Abscess. Okay. And in this case, now we are experts about this pathology. It's a 17-year-old girl with prolonged cortical treatment and bilateral hip pain and submitted to some kind of surgery. Which kind of intervention? You have here the bone, the fused images. There is a fibula graft, a stem cell. Yes, on the left side. Yes. Well, I think this was on both. No, it's just on the right. You're true. Yes, yes. Okay, and in this case, this is a 22 months old baby with is a battered child. How many fractures can you see here? What about the skull? Yes. All the coronal seizure seems to be abnormal. And with that, we have to be very careful because very often it can be a lesion of the suture, but without alterations on the CT. Okay. And what about the maxillar and the mandibular? It's a normal uptake? No. And what about some cervical vertebra? Also. And then we can go here. Here you can see a lesion here on the coronal, and here you can see also on the tibia a fracture, an anterior fracture here. Yeah. It was a battered child with many lesions. In this case, we perform a CT with a low dose. You can see about the quality of the CT. And this case, 17-year-old boy with a previous Epstein-Barr virus. I think that I have showed you this morning this image, but now we can see in more detail some of the images. What do you think it is this? It's an increased uptake on the distal part of the fibula. Is this normal? Why do you have this uptake? Yes, it's the distal part of the fibula, and they have to fix this distal part of the fibula to the tibia, and for this reason, here there is an increased uptake. And what do you can see more here? This is normal? This is at the level of the hips, and you can see very well the repermeabilization of this side. And here, what's that? She had an osteonecrosis of both femoral heads. And osteonecrosis after corticoid treatment never go only one. We have always more. Is an osteonecrosis of the talus. Okay. It's well seen, not? Okay. Another case. What do you see? What's that? Look, it's like a tunnel here and here. It was an osteonecrosis treated with forage and stem cells. Which is the best hip? This one, okay? And here you have the coronal images, and here you have the transversal images, and you can see very well the different degree of bone reconstruction in both hips, okay? You have the CT, here the magnetic resonance. The magnetic resonance doesn't detect very well all this bone reconstruction. Okay? Another adult. What do you see? What's this? A lesion, a cortical lesion? And here? What's that? Yes, that means several bone involvement, metastasis, and the sternum also, and cold lesions on the bones. What do you suggest as diagnostic? Myeloma, again, okay. If we have problems with the myeloma, with the bone scan, then it is recommended to perform a fluorine PET. And the last case. Half a millicurie of fluorine. Images obtained during the first 3-4 minutes of the whole body without CT. And images obtained 45 minutes after the injection. Here we have obtained these images with 1 minute per bed, and here 3 minutes per bed. How many fractures do you see? The scalp, the coronal suture as before, the right humerus, and the other one is very mild. Look at the right radium, here. You can see now, a little bit. You can go to the, well, these are the complete blood pool images. And these are the complete reconstruction of the late phase. Look here and here. Okay? The radiologist with the X-ray survey detect only the right humerus fracture. Nothing about the skull and nothing about the right radius. Here you have the coronal images of all the body. And here you have a triangulation of the distal right humerus and the triangulation of the area around the left orbita, in which you can see very well the symmetry in the uptake of this area from one side compared to the other. And here there is a triangulation of the lesion in the middle of the right radius. Look. Okay? The blood pool of this lesion was normal. That means this is new or old. It's an old one. And the other two, the blood pool was positive. Look at this positivity and look at this positivity. And here there is no an increased blood pool. That means we have 3 fractures. The tracer was fluorine, and the diagnosis was battered child with several fractures in different times. Okay. And this is all. Thank you very much.